Thank you very much for taking the time out of your busy lives to spend a little time with me and learning a little bit more about BPH. So what I'm going to do tonight is I'm going to go through this set of slides, tell you a little bit more about BPH and the treatment options. Probably take about 20 to 30 minutes, and then we'll have a 20 to 30 minutes for some questions. So without further ado, let's get going. So that's me. As Rachel mentioned, I went to Emory, did my residency in Colorado. I've been a urologist now for, 32 years. I do all sorts of different procedures in urology, but I do specialize in BPH. So that's pretty much what we're going to cover today. We're going to talk about the prostate in general, BPH, and what the treatment options for that are. So what's the prostate? So the prostate is a gland. It sits at the base of the bladder, and it surrounds the urethra, which is the urine channel where the urine passes from the bladder to the outside. What does the prostate do? Well, it produces a fluid that transports sperm during the ejaculation process to allow a woman to achieve a pregnancy. So it actually grows starting when a man is about 20 or so, and sometimes starts to get enlarged in men in their 40s and 50s. So there are several different conditions that affect the prostate, and they can be somewhat related, but they're separate processes. So enlarged prostate, or BPH, which is what we're going to discuss tonight, prostatitis, which is more an inflammation of the prostate, not necessarily an enlargement of the prostate. And then there's prostate cancer. And we're going to concentrate again on the BPH, or enlargement of the prostate. So what is BPH? Well, first, the B is benign. It means it's not cancer. The P is the prostate. And H is hyperplasia, which means a proliferation of cells, meaning too many cells. So because there are too many cells, the prostate gets enlarged. Some people say swollen, and therefore that's what blocks the flow of urine in some men. So as far as BPH and prostate cancer, sometimes when I tell patients that they have an enlarged prostate, they immediately are worried, well, if it's enlarged, it's got to be a growth, it's got to be cancerous. And that is not true. So, most men that have an enlarged prostate, BPH, do not have prostate cancer. It doesn't cause prostate cancer. There are two separate things that happen to the prostate. Now, as far as the symptoms, so with early prostate cancer, there really are no symptoms. And that's why urologists recommend that patients get a PSA. Once prostate cancer has advanced to the stage where it's causing symptoms, then it's often too late to cure it. But for this talk, BPH, benign prostatic hyperplasia, is not cancer. People can have an enlarged prostate and cancer, but they usually exist one or the other. So what happens with the enlarged prostate? So you see the picture on the left shows a normal prostate, a normal bladder, where the urine goes through the middle of the prostate and out through the urethra to void. The way I like to describe this to patients, and it's a little hard when I'm not doing this in person, but I'll try. So I think of the prostate as a bagel. So the urine flows right through the middle, through the hole. So in some patients, the prostate gets large overall in size. And in some patients, it just gets enlarged in the middle where the urine flows, and it compresses the channel so that the urine can't flow as easily. And that's the typical situation. So what are the symptoms? Well, you guys can probably all tell me what the symptoms are. Frequency, going to the bathroom often, urgency when you have to go right away, discomfort with urination, a slow flow, feeling like the bladder is not emptying, inability to stop the flow of urine, and eventually what can happen is this can lead to urinary retention, which is the inability to urinate. So it's a good idea to try to intervene, to do something about it before it gets to that point, because by the time it gets to that point, you can cause damage to the bladder, to the kidneys, which is sometimes irreversible. So we try and intervene and do something before it gets to that serious situation. So BPH definitely affects men's quality of life, although a lot of men put up with the symptoms for a long time. But when we ask men if they're unhappy, 95% say they're unhappy and they don't want to spend the rest of their lives like this. They say it interferes with normal aspects of their life. For instance, if somebody's going to go for a long car ride, they'll not drink for a couple hours before and become fairly dehydrated. About half the men do experience some sexual problems, which can actually be associated with the BPH, but is usually a separate issue. And it affects their partner as well, getting up in the middle of the night, affecting their partner's sleep and other daily routines. So who gets BPH? Well, it's more common in men as we get older, starting at the age of 50. I have treated and see patients in their 40s, but typically it's men in their 50s through 80s. 50% of men in the 60s will have some problems with BPH. And about 80 to 90% of those that are 80 or 90 years old will have problems. It's a big problem in the US, and that number, 14 million from 2010, I bet it's over 20 million now, which is why you see so much direct-to-consumer advertising for this, because it's a big business as far as pharmaceuticals and supplements. As far as lifestyle, obesity, lack of exercise may increase the risks. So what do we do to figure out what's going on? Do you really have an enlarged prostate, or is it something else that's causing the symptoms? Well, first we start with a good history. And I think that, a doctor that sits down and spends time listening to what your symptoms are, I think I get a lot of information just by listening to a patient describe their symptoms. And right off the bat, I can tell whether or not it's their prostate that's most likely causing the problem. We often will do a digital rectal exam to feel the prostate. Primarily, that's actually not feeling for prostate size. It's more feeling for whether there's any lumps or bumps that might make me suspicious for cancer. We do various other tests, including a flow test where we measure the flow of urine. We often measure the amount of urine that's left in the bladder. That's called the post-void residual. And these are all simple tests that can be done in the office. We use questionnaires, primarily the International Prostate Symptom Score, which is a 7-question questionnaire that quantifies how severe the symptoms are. And then finally, another test that we use is cystoscopy, where we actually look in with a little lighted telescope to see how the prostate looks, see how much blockage it's causing, see how the bladder looks. So let's move on to treatment options. So there are 3 levels of options. There's behavior, there's first-line treatments, and then there's surgeries. And we're going to talk about all of those. As far as alternative medicines or supplements, so a lot of men, I'm sure you've heard of saw palmetto. A lot of men take that. Some men say they think it helps. Most men don't think so. There have been studies of saw palmetto, and there is no indication from a scientific standpoint that saw palmetto helps at all. So, if a patient is taking it and they tell me they're doing great on it, that's fine. They can keep taking it. So one option is just observation or watchful waiting. And what this involves is dietary lifestyle modifications. So adjusting the diet, limiting fluid intake. I would suspect that by the time your symptoms are such that you're interested in spending 45 minutes of your life watching me talk about this, that you're probably beyond that. But, a lot of patients do that at first to try and basically live with the symptoms. But, as I tell patients, that the treatments now are much better than they were 20 years ago when your dad had problems. And so it's a lot easier for patients to move on to get help and get treatment. And actually, let me go back to that. So one of the issues with just keeping an eye on it is that some of the time patients don't realize how bad their symptoms are because it's so gradual. And I see patients in the office at least a couple of times a month that come in and they have a liter of urine, 1,000 milliliters, a liter of urine, which is about 35 ounces, left in their bladder after they void. And by that time, the bladder has become so stretched out that the muscle fibers are damaged and may never function properly again. So we really want to take care of it before it gets to that point. So what about medications? So there are two classes of medications that are used for enlarged prostate. The first is called an alpha blocker. The most common ones are Flomax, which is tamsulosin, uroxetrol, alfuzosin, and the newest one, which is probably 20 years old, is called Rapaflo or Solodicin. So all of these medications work about 75% of the time. About 25% of patients have side effects. And as you can see here, a good number of men stop taking the medication within a year for various reasons. Some of the most common side effects are that it can cause a drop in blood pressure. It can cause fainting, dizziness, feeling tired or fatigued. There's also a side effect called retrograde ejaculation that these drugs have in many patients. There's another class of medications called the 5-alpha reductase inhibitors. The two drugs in this class are called finasteride and dutasteride, previously known as, I'm blanking on that, Avodart and Proscar. They're generic now, finasteride and dutasteride. So they are designed to block the hormones in the prostate. The problem with these medications is that they only work in about 50 to 60% of patients, and it takes about 6 months before you know it's going to work. So I use these medications for very specific indications, but not generally. And what I'll say about the medications is that we used to think that we should start all patients on medications before we do surgery, because the surgical options were pretty drastic. But that has changed over the past 10 years with the advent of the more minimally invasive treatments, which have much less side effects. And so now it's acceptable and part of the AUA guidelines that we do not need to try patients on medications first. We can move straight to other therapies if that's what the patient wants. So patients of mine, I give them the option to try a medication or to move straight into more effective therapies. So first, we're going to talk about the minimally invasive BPH procedures. So water vapor therapy, or Rezum, is putting steam, that's steam, water at 100 degrees Celsius, 212 degrees Fahrenheit, into the prostate in a procedure that takes less than 5 minutes. What happens is the steam heats the tissue, heats the cells, it kills the cells, and then the body resorbs that tissue so that the prostate channel is opened up. This procedure has been around now for almost 10 years. I was involved in the clinical trials back in 2013, 2014 that got it FDA approved. It was FDA approved in 2015. And so since then, it's been commercially available. It's a very good treatment option. It is quick. It's easy for patients. They don't have to undergo general anesthesia. I do 98, 99% of my treatments, the water vapor treatments, under local anesthesia. I numb up the prostate, the nerves to the prostate really well. And like I said, the procedure takes about 5 minutes. It is a durable treatment. And in the study, we looked at patients for 5 years. And what we found is that only 4.4% of patients need to have another type of surgery over the next 5 years. And that's an important number to remember. Since I've been doing the Rezums in 2015, I keep track of all of my patients. And in my patients, there's about a 3% chance of needing a second procedure within the first 5 years. So Rezum is an excellent option. The potential side effects, some patients can have worsening of their symptoms for the first 2 to 3 weeks before they start getting better. There is a need in most patients to have a catheter after the procedure. What I do is allow patients to try to void after the treatment. If they can void most of what I put into the bladder, then they can go home without a catheter. There is a chance of what we call retrograde ejaculation, or decrease in the amount of ejaculation. I would say that the chance of there being no fluid that comes out with ejaculation is only about 5 to 7%. with Resume. So the next option in the minimally invasive category is prostatic urethral lift, otherwise known as UroLift. So UroLift is another option. It does not get rid of any tissue. It puts these staples or clips into the part of the prostate that's causing the blockage and pushes them out of the way. It's a procedure that I don't do because I feel that the other options are better, but that's just my opinion. There are a lot of urologists who do this procedure. What I would have you note, and one of the reasons that I don't do this procedure and I do Resume instead, is because if you look at the surgical retreatment rate, so if you remember with Resume, it was 4.4% at 5 years. With the UroLift, it's 13.6%. So about 3 times higher chance that it's not going to last for 5 years. So that's one of the primary reasons that I don't do it. I suppose in a patient that is elderly toward the end of their life and they don't really care about 5-year results, if all they're interested in is the first year or so, then this is not a bad option. So the next we move into slightly more invasive, although I still consider this minimally invasive treatment, laser therapy. There's several different lasers. There's a green light laser, there's HoLEP, and there's thulium. I tend to use the green light laser. So green light laser is an excellent procedure. It does have to be done asleep, so it's not quite as minimally invasive as the Resume. Takes about 45 minutes to an hour. It's outpatient. I do these in an outpatient surgery center. Patients go home the same day. If you notice down at the bottom, the retreatment rate, surgical retreatment rate is very similar to Resume. And again, 3 times less likely than with a UroLift. So it's pretty rare that a patient needs treatment again. The one thing about this treatment is that because so the laser goes in and vaporizes the tissues to open up the channel. So the channel's open right away, so therefore you don't need a catheter as long, and your symptoms improve more quickly. The downside is that there is a higher chance of the dry orgasm or the retrograde ejaculation. It's about 30 to 40% with this procedure compared to about 5 to 7% with the Resume. So it's a good option. There are some patients who I recommend Resume, some patients I recommend the green light laser. A lot of patients, I offer them the options, the pluses and minuses, and they kind of tell me which they think sounds better for them. So the one of the more invasive options is called the TURP. The TURP has been done the longest of any of these procedures. It was the first procedure done for this problem. It stands for transurethral resection of the prostate. I have not done one of these in over 10 years because of these newer treatments that have come out in the past 10 years that are much less invasive, have very similar success rates, and they have this has much higher side effects. If you notice again, the surgical retreatment rate, 5.8%, which is even a little bit higher than with the Resume and the green light laser. So I don't do TURPs. There are urologists who still do. Prostatectomy, and really that refers to a simple prostatectomy. It's not the same prostatectomy that you would have if you had prostate cancer. So basically this is done only for very large prostates, usually over 150, 200 grams. And I kind of liken it to, we take the prostate and think of the prostate as an orange. You open up the shell, the skin of the orange, you scoop out the meat, and you sew the shell back together. It has to be done in a hospital. It's a lot more invasive. The catheter has to stay in longer. And it's really only a procedure for really, really large prostates. So what about insurance? I would say early on, 5 years ago or so, some of the insurance companies did not cover these newer minimally invasive treatments. They have learned that the treatments work. They're less expensive than the hospital-based treatments. And so insurance now most insurances cover all of these treatments. So in summary, we've talked about the prostate, we've talked about how it works, we've talked about prostate enlargement and what problems it causes. We talked about the treatment options, the watchful waiting or lifestyle modification. The first line therapy is the medications, which do not necessarily need to be used before moving on to the water vapor or to the Urolift. And then, I still group the laser therapy. I don't consider that in the surgical procedure category because there's no cutting and it's outpatient. So I put that into the first line therapies as well. So basically, it requires seeing your urologist, being evaluated to see which option is the best option for you. And so I think that that covers the topic pretty well, but I am happy to answer any questions. So, Rachel?